The peak number of eggs that you have in your body when you are at 20 weeks gestation in utero. It's all downhill from there. People often come in and say, I want to do that test where I find out how many eggs I have. Well, there is no test to tell you how many eggs you have.
Mine was 0.5. And I did get pregnant naturally three times. It's the egg quality, not the quantity of eggs.
I caution people about it because I think it'd be nice to try to get to know your cycle for a while and not turn this into a full-time job. But I do see a big phenomenon right now of people heading straight from birth control into early perimenopause, pregnancy, maybe a couple pregnancies, and now they're postpartum, and they don't even realize that their postpartum is completely being impacted by early perimenopause.
Hi, I'm Ronit, WeNatal co-founder. Today I'm excited to interview Dr. Suzanne Gilberg Lenz, who is my good friend, was also my OBGYN and helped birth Eden, my first. She's also a renowned menopause expert and an overall women's health expert here in Los Angeles. I'm excited to dive into all things fertility from the perspective of an OBGYN. We talk about ovulation, when is the best time to have sex, and all of the things that you need to know if you're trying to conceive. Dr. Suzanne Gilberg Lenz, I'm so happy to have you here today. You are my, 15 years OBGYN and turned bestie. And I am so excited to talk to you today about everything that women need to know about their cycle, when they're ovulating, pregnancy, and even postpartum. And maybe we can even touch on some like perimenopause.
Whatever you want to talk about, I'm here for it.
So let's jump in. Our community is mostly in the trying to conceive phase of life. So what do they need to know? And I feel like for me, when I was trying to conceive that first baby, the first year was really just trying to figure out my cycle and when I'm ovulating, because I feel like up until the point that you're trying to have babies, you really don't understand much about your cycle. So can you talk to us a little bit about what is the cycle? What are the phases? How do you know that you're ovulating, etc.?
Yeah, absolutely. I mean, I think you're right. I think what happens is we focus a lot on managing our cycle and how our cycle is either going to disrupt things or we're trying to not get pregnant. So now all of a sudden we're trying to get pregnant and we have no idea what's going on. So first of all, let's break it down. Let's break down the menstrual cycle. So when your physician, when your gynecologist talks to you about the menstrual cycle, we're not talking about just the bleeding phase. We're talking about the entire experience hormonally. What happens is, basics. Day 1 is the first day you bleed. I mean, if you spot a little bit, I don't know, you can sort of play with what that day is. But usually I tell people the first day of actual flow would be day 1. So we are looking at a couple of different things, duration and interval. So how many days from day 1 of one cycle to day 1 of the next? And that is important because when you're going past around 32 days or so from interval counting, you may start getting into more difficulty with ovulation and tracking ovulation or the quality of ovulation or even ovulating at all. Okay, so tracking your cycles is super important. So interval is important. How many days do you bleed? That first part is menstrual, right? Your menstrual phase where you're menstruating. Now you move into follicular phase. What's happening is that your brain and your ovaries and your uterus are having this conversation that's very complicated and nuanced. And the idea is to help select a follicle where an egg is going to be and help that grow enough so that it gets to the point around mid-cycle when you will release that egg and ovulate. That's a very complicated soup of hormones and a really beautiful, harmonious, actually, conversation much of the time, but not always. So that's the follicular phase. That's that first part after menstruation leading up to ovulation. Then you have ovulation itself, and we're going to talk about that, how to understand it and identify it. Once you release the egg and you do not conceive, you're moving into what is the luteal phase, right? So your body has to get the message. The egg is there, it's hanging out. Progesterone is now being made in higher amounts in order to support a possible pregnancy. When you don't conceive, all those hormones start to decrease, shift, you move into menstruation again. So you're going to release the hormones you're withdrawing from those higher levels of hormones in order to accommodate a reset so that your body can try and get pregnant again. So everything is working for you in that way. But if you don't understand that these hormones are switching and changing and you're going to feel different, you're going to have different symptoms, these hormones are going to exert different effects, it could be confusing. I think ovulation gets confusing for people a lot, right? So mid-cycle depends on how, now you understand the cycle is that whole thing. The best thing to do is to just observe your body. Knowing when you ovulate is more about tuning in. There's some very specific symptoms that people seem to feel. Some people can actually feel cramping or pinching in their lower abdomen. I think most people aren't aware of that. The discharge changes pretty significantly. So people will notice a more egg whitey, goopy discharge. That's not the egg, by the way. It just happens to look like an egg white.
Yeah.
It's the cervical mucus, which is getting goopy and thick in order to help trap sperm, by the way.
Yes.
To help transport it. So these are some things people may notice. Some people will start to notice almost a mini PMS experience. Maybe they'll get some breast tenderness. Maybe they'll get a little fatigued or moody. But that discharge is, I think, one of the most reliable ways of noting it. There are ovulation kits that you can buy over the counter commercially. I think I caution people about it because I think it'd be nice to try to get to know your cycle for a while and not turn this into a full-time job.
Yeah.
But they can be helpful because they will take a look at the various signaling hormones, luteinizing hormone, follicle stimulating hormone, estradiol, and help to put together a picture of, hey, you're getting closer to when you're going to ovulate. It looks like you've ovulated. You already ovulated, so that you kind of know where your peak fertility is going to be, because when the egg is released, you have about 12 to 24 hours to make contact with the sperm. The egg itself is not going to live that long. The sperm can live for 3 to 5 days. So understanding when you're fertile is going to be a combination for heterosexual couples of really understanding how all of these different moving parts interact. Basal body temperature is something people look at as well. I personally find it confusing and stressful.
Yeah.
I'm not a huge fan of it, but if somebody wants to do that, you can do your temperature first thing in the morning. I guess if you have an Oura ring, there's probably a way to do it.
It tracks
as well.
it automatically.
Yeah. So,
but back before the Oura ring days, I felt like it was so complicated to open your eyes and take your temperature right away.
Exactly.
And especially if you're trying for like baby number 2, I don't know any morning that you just like wake up leisurely and like can take a temperature.
Totally. Right. So you're attending to the business of like keeping that other one alive. Yeah.
Exactly. Yeah. Okay, so peak fertility is before you ovulate.
It's exactly. It's right as you're leading up to ovulation, because again, you're trying to kind of hit it like before and during. After, it's going to be, it's not that it's too late. Like I said, you've got a 12 to 24 hour window.
Yeah.
But the good news is the sperm can hang out for a couple of days.
Yeah. So it's better to essentially, if you're trying to have baby, kind of have sex maybe on like week 2 of your cycle, leading up to.
Well, assuming you have a 28-day cycle, right? So this is where plugging things in, and I mean, everybody's different. Some people are like, I'm a very visual learner, so I think having some tracking where you see a graph might be helpful, because you can see where you're getting closer, right? But I think that midweek, like leading up to ovulation, that's where you want to target your activity.
Got it.
I mean, have fun too.
For sure. For sure. But sometimes I feel like when you're trying, it doesn't get fun anymore.
No. Yeah.
And speaking of that, how often, like what is the frequency of intercourse?
Yeah. There's a lot. I mean, there's data on both sides. I think this is obviously assuming that your partner has normal sperm and normal sperm counts and functionality and stuff like that. I think every other day is probably the best. I mean, you can do it every day, but I think it can turn it into a chore.
Yeah.
And also, depending on what studies you look at, there could be an effect where you're like, don't have as much sperm in the semen if you're having sex every day.
Yeah.
But it also depends like what window are you using. If you're using like 3 days, I think it's fine to do it every day. If you're using 8 days or 10 days, maybe every other day.
Got it. Got it. And then what about orgasm? Does that help conception?
Female orgasm, I don't
Yes.
think there's any data to suggest that. It certainly is much nicer, but he's the one who's got to get his sperm out there.
Yeah. But the contractions from the
I don't know if there's good data on that. I mean, that would make sense, like in some, like there may be some biological or physiological impact, but I'm not aware of like large studies that show that it's required. Let's
yeah.
put it that way.
Okay. Okay, so you do all these things and you get pregnant. What's next? I know that oftentimes you get a positive pregnancy test, and then there's like this whole gap between when you go see a doctor, which
Yeah.
is typically 8 weeks
Yeah.
now. Like, I'm not that person. I'm
Yeah.
that person that calls
Yeah.
you and is like, I'm coming in right
Yeah,
now.
yeah.
So what is your suggestion on what's ideal for patients to do?
Well, I mean, here's the thing. This is a lot about sort of the business of health care and medicine, and a lot of it's going to depend on what accessibility people have. I think having, when you're this aware of your cycle and you know you missed a period and you can get, a really sensitive home pregnancy test that's going to tell you when you're 5 seconds pregnant, it's pretty stressful. So here's the thing. If you can go in to see a practitioner, the thing is that there isn't going to be anything to see. You could do blood work. You could go in and do lab work and look at your beta HCG levels and possibly progesterone levels to see is early pregnancy proceeding in what appears to be a normal fashion. But until you can do an ultrasound, and really you're not going to be able to see anything valuable till about 6 weeks of pregnancy, which is not 6 weeks from your period, or like this is a calculation, right? And it's like, 3 months ahead and 2 weeks back. It's a whole thing. Like we have a wheel. I don't even know how to do that calculation in my head.
Yeah.
So the thing is that you're not going to see anything on an ultrasound. So getting freaked out and being like, I need to come in and do an ultrasound, there's nothing to see right now. It's going to take a while to see anything. If you have any risk factors, you've had previous miscarriages, you have other high risk medical conditions, you've had scarring on your fallopian tubes, you have endometriosis or maybe ulcerative colitis, or have had some major infection where you might be at risk for a tubal pregnancy. Maybe you've had a previous tubal pregnancy. You really do want to alert your physician as soon as possible so that you can be tracking the hormone levels and making sure everything looks okay and that you're feeling okay. But having the comfort of at least a conversation with your practitioner is ideal. Not everybody has access to that.
Yeah, I always say that my number one recommendation for women who are trying to conceive is to find a practitioner that they feel like they can have a conversation with.
Yeah. Yeah.
So important.
Yeah, absolutely.
And what about progesterone when you do find out you're pregnant? I know that for me, I believe with my third pregnancy, second and third pregnancy, I supplemented with progesterone because of that like worry of miscarriage.
That's definitely not standard of care. And I know in our community we're just highly sensitive to people's anxieties, and the data on that has never been very well accepted, but there is some older data suggesting that progesterone needs to be over a certain number, whether that's 15 or 20. I think not everybody agrees. And so if you have a lower progesterone level, one of two things is going on. It's not a normal pregnancy, and nothing we do is going to change that because it's going to be a miscarriage.
Yeah.
So giving you progesterone isn't going to change that.
Yeah.
But I think for people who are at risk or are anxious, there's really no harm to giving progesterone because people feel like they are doing everything they can to attend to the need. There is some older evidence showing that there are people who don't make enough progesterone. We talked about that a little bit earlier.
Yeah.
From the ovaries in the first part of the pregnancy. And so supplementing it will help bridge that gap from when the ovaries are responsible for making progesterone, that is literally keeping the pregnancy going, to the time when what's called the it's essentially going to be the placenta, the
Mm-hmm.
tissues that will become placenta start taking that job over. But that takes a number of weeks. And so until you get there, the thinking had been, well, we'll supplement progesterone for these people who are not making enough in their ovaries to help continue the pregnancy.
Mm-hmm.
I'm there's going to be a lot of people watching this that their doctors will be absolutely not. That is not evidence-based. We don't do that. In our community, we've always done it.
Yeah, that's super helpful. And then you talked a little bit about that like longer cycle, which to
Yeah.
me sounded like
Well, it's more
potentially
PCOS. Yeah.
PCOS.
Yeah.
So can you talk about what's PCOS? And I know that it's the number one cause of infertility.
Mm-hmm.
So what's going on
Mm-hmm.
with that? And are there ways that people can combat PCOS?
Absolutely. So PCOS does affect a large number of people, maybe even up to 15% of people have some kind of PCOS variant. So PCOS stands for polycystic ovarian syndrome. It's sort of, the name that it was given in the past. It's really a syndrome of changes that result in somebody either ovulating very late in the cycle or not ovulating at all. So some people will have a 35 or 40-day cycle. Some people get 2 periods a year.
Mm-hmm.
They're just really not ovulating at all. So obviously, if you're not ovulating on a regular basis, or you can't predict when you're ovulating, it's going to be impossible to get pregnant spontaneously, or very,
Yeah.
very challenging, right? There's also different variations. I mean, basically, insulin sensitivity issues. So they look and appear often like pre-diabetic or diabetic, and so they do respond to interventions, both lifestyle, dietary, and supplements, and then medications that would help to increase insulin sensitivity and decrease the disruption to ovulation, and then overproduction of androgens, right? So, which also can decrease the ability to ovulate because those androgens are elevated and they're suppressing ovulation.
So essentially high testosterone.
It's really, yes, I mean, I'm saying androgens because it's not just testosterone. A lot of what we look for when we're testing is actually something called DHEA, which is a precursor. So, and these are where we can get, people who have hair patterns that are different, acne, they can have weight issues or difficulty losing weight, especially like centrally. But not everybody has the same thing. It's not one thing.
Yeah, it's interesting because I have seen a lot of people that are not like
Right.
high weight,
Yeah,
like
not at all.
they're like
Right.
extremely thin,
Yeah.
they're
Yep.
fit, and
Mhm.
yet they have been diagnosed
Yep.
with PCOS.
Yep. Yep. Yeah. So that's the thing. I think understanding that you have it so that you can get ahead of it, and then having an action plan so that you, meet your goals, right? Like we want, if you want to be getting pregnant, we want you to get pregnant. And there are a number of people who are able to manage this without medication.
Yeah.
It definitely requires a lot of expertise and a lot of commitment, especially when it comes to, sort of the dietary changes and things like that. And things like inositol. There are definitely, there are some supplements and herbs that have been used with pretty good success,
Yeah.
but you need to be working with somebody who knows how to do this.
Yeah.
Or medications, whether it's metformin, which can be used for diabetes, or, managing in a more diabetic style, or Clomid, or some other ovulation induction manner.
Yeah.
You don't want to, we're not going straight there for everybody.
Totally.
Yeah.
WeNatal actually has inositol in it
great.
because of that blood sugar regulation factor that it has.
Yeah.
Because regardless of PCOS, it's just good to stabilize your blood sugar
Absolutely.
pre and during
Yeah.
and postpartum.
Exactly.
Yeah.
Exactly.
Okay, I love that. Okay, so let's talk a little bit about AMH. I think that's
Yes.
like a hot topic with our community.
I feel like this leads into it. Yeah.
And back in the day when I was single, I said to you, Dr. Gilberg Lenz, I want to test my fertility.
Yeah.
So you checked my AMH,
Right.
among other things.
Right.
So I'd love to know, like, how do you check someone's fertility? And then if you have a low AMH,
Yeah.
like I did,
Yeah.
what are next steps?
Yeah. So here's the thing about AMH. So AMH stands for anti-Müllerian hormone. Anti-Müllerian hormone is usually, it came to us through the fertility world. And really, originally it was being looked at and as has been used for ages in order to help predict who is going to be a good responder to assisted reproductive technologies, right? The reason is that it is a proxy for ovarian reserve. And this is really important because people often come in and say, I want to do that test where I find out how many eggs I have. Well, and there is no test to tell you how many eggs you have. But the AMH is the closest approximation we have to it. It sort of has bled into fertility preservation. It's technically not anything more than a predictor of what I just said, but it is a proxy. It's the best we have. So it's telling us that you have enough or not enough eggs left. And we also have to be concerned about quality of eggs too, right? So I think maybe people don't realize, but the peak number of eggs that you have in your body are when you are at 20 weeks gestation in utero. It's all downhill from there. But you have like tens of millions of eggs. You're born, maybe you have 2 to 3 million eggs. And by the time you get to, an age where you would be appropriately fertile, you still have maybe 200,000 or 300,000 eggs. But you're losing eggs. And it's not just like one cycle at a time, by the way, right? Because sure, you're ovulating and not getting pregnant, but also the eggs, when we do what's called a follicle check on an ultrasound, so that's another way we can look. Those are, remember we talked about the follicle developing, right? So when the brain is telling the ovary, hey, get ready, we're going to ovulate in 10 days or 14 days, everybody's kind of getting in line and getting excited, right? And you develop a little fluid-filled area there's an egg in there. One of those is the dominant follicle that's going to ovulate. Maybe you ovulate, more than one. The rest of those, you may lose those. So you're losing a certain number of eggs every month, not even ovulating. Don't freak out. Right? Like you got hundreds of thousands of eggs. So there's a lot of reasons why we're losing eggs. The AMH is going to give us, again, that proxy for, do you have enough eggs to spontaneously conceive? Should we be intervening? The number, because I know you're going to ask me, what's the magic number? I mean, it depends on your age and it depends on a lot of other qualities because that's not the only thing that determines fertility. But you want to be over one. I mean, do people get pregnant when their AMH is less than one? Sure. Do they predictably get pregnant and have a healthy pregnancy? Far less often.
Yeah. Well, in my case, you probably don't remember.
I remember.
But
I remember the numbers, but I remember
mine was
dismay.
Mine was 0.5.
Yeah.
And I did get pregnant naturally 3 times. 2 with viable pregnancies. So
that's a great example.
I always tell people it's the egg quality, not the quantity of eggs. And if I probably went down the route of IVF, I probably wouldn't have been a successful candidate.
And you might have ended up with donor eggs or something like that, which is a great choice for a person who can do that. But I agree with you. But you were a great learning experience for me too. I mean, I was already kind of open-minded and doing a lot of things, but I learned a lot by watching you because you really doubled down on your lifestyle factors, on the right kind of supplements, understanding what your body needed, on managing your thyroid, on inflammation, and sort of diminishing your immune response and things like that. I remember very distinctly how you were working on those things, and these are things that have been shown to be effective. They're very hard to do. You have to have a lot of support, you have to have a lot of discipline, and you have to be resilient because you're going to have to be prepared for a lot of people around you, including practitioners, to just be like, what are you talking about? But nutrition is incredibly important because inflammation, especially in a situation like that, is really important. So, I mean, that's why I think intentional, thoughtful supplement use is critically important, especially when a lot of people are going to come into this period of life like, okay, now it's time to get pregnant. And then they get hit with a diagnosis, or they didn't even know there might be something that wasn't working so great.
Yeah. And I know men too, I feel like,
yes,
often their sperm quality indicates an underlying issue. And, some reproductive endocrinologists will say that couples going straight to IVF actually hurts men's health because in general, because it is a time where they can actually like work on their health and work on all of the things that will then in turn impact their sperm quality. But when you just like need that one sperm,
Yeah.
you often are kind of like bypassing those health
Yeah,
issues that
rather
are
than
coming
seeing that
up.
as the yellow flag or the red flag that it
Yeah.
is. That's really, really interesting. Yeah, I mean, all of these challenges can be opportunities, but again, not if you don't have the right resources.
Yes.
And I think the other thing to think about here for both women and men is what other medications are you on? Could those be changing function? There's nothing that's particular. I mean, I think I'm a little obsessed with this because I just heard this on a podcast with two of my friends this week, but I did not know, but of course it makes sense scientifically that statins decrease testosterone because statins bring cholesterol down. Cholesterol
Mm.
is the substrate from which testosterone, estrogen are made. So I'm not saying everybody go off your
No.
statins, but
Yeah.
and we don't know that there's any
It's just having
correlation with
awareness.
fertility or sexual health or anything else, but it's really interesting.
Yeah. And
Yeah.
then speaking of, things that, maybe some myths that
Yeah.
we've been hearing that can impact fertility, birth control. That is a big one.
Yeah.
Does birth control impact fertility? If someone is on birth control and they want to have a baby,
Right.
when should they stop?
Yeah.
Talk to me about that.
Well, I mean, obviously birth control, the point of birth control is to impact fertility. Clearly, I know you understand that. I mean, right now we're in a moment of like, I think moral panic almost about birth control. And I think when you say birth control, you mean hormonal contraception, right?
Yes.
Because when I say birth control, when I ask people about birth control, they're like, "Oh, I've never taken the pill." And I'm like, "No, no, no, no. Any contraception, anything that you've used to not get pregnant, right?" So hormonal contraception and specifically ovarian suppression, right? So that would be the birth control pill, the shot, Depo-Provera, the implant, not the
Mm-hmm.
IUD, but the arm implant, um, the NuvaRing, patch. Almost nobody uses that. But so anything that is basically what those medications do is disrupt the conversation between the brain and the ovaries so that you're in a steady state, you're getting some hormones so that you're not having no hormones, but you're not allowing for that peak and valley for the release of the egg. The whole point of that kind of birth control is stopping ovulation. The majority of people will come off of these and resume normal ovulation and normal cycles when they're off. For some people, it could take up to 90 days for your cycle to
Oh.
resume. But here's the caveat. When did you start? Have you been on the pill since you were 14?
Mm.
Did you start at 17 because you had irregular cycles? Because guess what's going to happen? You're going to come off the pill and you may still have irregular cycles,
Yeah.
right? What is is there an underlying condition that didn't get picked up? And I'm not criticizing that because there are reasons why people start the pill that are totally legitimate.
Yeah.
And is it ruining your fertility forever? I don't think the evidence supports that. Here's the other thing that we